In Tune. Conversations on audiology and balance. An Inventis podcast.
Welcome to a new episode of In Tune, the Inventis podcast on audiology and balance. Today we have with us Dr. Marco Boldreghini, research technologist at the Department of Surgical Sciences at the University of Turin, specialized in clinical and rehabilitative vestibology. In fact, today we will be talking with him about vestibology and in particular about vestibular rehabilitation. Dr. Boldreghini, welcome to In Tune.
Thank you very much. I appreciate the opportunity you've given me to take part in this podcast. It's a real pleasure.
Thank you. So to start and break the ice a little, I would ask you to tell us a bit about yourself. What has your journey been like, and how did you come to develop a passion for vestibology and in particular for vestibular rehabilitation?
Yes, I'd actually start from the end, that is from what I do right now. At the moment, as you correctly introduced, I am a research technologist. This is a role that has been officially established by regulation very recently as a stable position within universities. It is essentially a research coordination figure. So, I deal with data management, coordination of clinical trials, technology transfer, and the design and management of technological infrastructures, with a particular focus on the protection of industrial property. This is the end, meaning that today I deal with research. Clearly, all these contexts are then applied to my primary activity, which is a branch of audiology called Vestibology. Therefore, in the clinical trials and experiments I oversee, I focus on researching biomarkers of vestibular compensation with a specific emphasis on reducing the risk of falls. And more recently, I've entered a fairly new world, wearables, meaning wearable devices that allow for the monitoring and biometrization of clinical parameters. Right now, we are working extensively with inertial motion sensors and eye trackers that allow us to measure the gaze point, which is particularly significant in vestibular alterations. We are seeing, in fact, that tracking eye movements allows us to obtain stable data over time in prognostic terms, as well as to monitor potential increases in the risk of falling. So that's what I'm doing now. Actually, I started with a degree in audiometry, followed by a master's degree, and in between a master's in clinical and rehabilitative vestibology, and another in research methodology and clinical trials. But even earlier, when I began working after my audiometry degree, I entered the private practice circuit. In that context, I was lucky enough to work extensively and above all, to see a huge number of patients. I was working in a very large otolaryngology clinic with a high volume of activity and services. The doctor in charge of vestibology, who had always handled it, was retiring at the end of his career. So this opportunity arose and I put myself forward. They trusted me, and from that point on, I started seeing 6 days a week from 8 in the morning until 8 at night, countless people with balance disorders. That, I must say, allowed me to distinguish between the healthy and the ill. Perhaps many of the evaluations I performed might not have been useful, but they nonetheless gave me a foundation to build upon. I then sought out academic information, studying vestibology texts deeply. They weren't emerging fields, but there was a lot of production in the 2000s. I then looked for the first masters in clinical and rehabilitative vestibology at the University of Florence, the Tuscan School of Vestibologists, which honestly truly formed me. Alongside them, Dr. Guidetti and Professor Pagnini were certainly influential. In addition to this, consulting scientific literature was truly relevant in acquiring skills, alongside carrying out clinical practice, which I believe is fundamental in a practical job where one must distinguish what works from what does not.
Excellent. So definitely a very rich journey driven by continuous training. In this regard, I'd like to ask you, perhaps for the benefit of our listeners who might be a bit less experienced, when we talk about vestibular rehabilitation, what are we actually talking about? In other words, what are the primary disorders that this field treats?
When we talk about vestibular rehabilitation, we have concepts from the past, the present, and what will likely be the future. In the past, we spoke of adaptation, habituation, and substitution, perhaps using an imprecise term, associating them with vestibular rehab. Today, vestibular rehabilitation is a set of procedures and physical movement techniques that reorganize the balance system by leveraging sensory inputs, especially vestibular ones, and visual vestibular circuits. We are moving more and more toward what we could call the future, a global rehabilitation of balance. What are the main disorders it treats? Well, chronic instability resulting from labyrinthine or vestibular damage, which can be either unilateral or bilateral. Of course, we are aware that the initial approach should be swift. Acting quickly following an acute event leads to a greater and better recovery. But unfortunately, we often find ourselves evaluating patients quite some time after the acute events have occurred. Despite this, rehabilitation principles work remarkably well, with good, I would even say excellent, prognoses for unilateral deficits that fail to compensate. The prognoses are also good, though perhaps slightly lower, for bilateral deficits, especially in elderly subjects suffering from chronic disorders, chronic disequilibrium, instability, and gait alterations.
Excellent. Now, regarding the patients themselves, can everyone benefit from it? Or are there situations where the vestibular rehabilitation approach is not indicated or perhaps should be used with caution?
Well, let's just say it's a physical therapy that generally has no side effects. It is sustainable for the vast majority of subjects who undergo it. Undoubtedly, the target is vestibular damage, either unilateral or bilateral, usually in a subacute or chronic phase. The idea is to reorganize the sensory systems by leveraging those that are particularly active in vestibular recovery. For the more technically minded, these are generally the vestibulosaccadic circuits. In my practice, this becomes what we've recently been calling visual vestibular rehabilitation. There are no particular difficulties in approaching the patient, nor any specific side effects. I believe we must very carefully manage patients with serious visual defects, significant strabismus, vision difficulties, or visual field alterations. We need to closely manage what they do with their eyes and head because the stimuli we provide, which generate optokinetic nystagmus or involve head movements during fixation, could cause discomfort in those with poor vision or gaze alterations in general. As for vestibular patients, rather than creating a flat denial or a recommendation against specific categories, we must pay close attention to those with fluctuating vestibular disorders, such as Meniere's disease. Vestibular rehabilitation is feasible for these individuals even in the active phase. It might be useful during intercritical periods, but it is essential to set the right expectations. Rehabilitation will not reduce the frequency of attacks, as the disease will continue to manifest over time according to its natural progression and how it phenotypically presents in the patient. Since I mentioned Meniere's patients, perhaps those who see the best outcomes from vestibular rehabilitation are those who, due to the severity of the disease, undergo ablative therapies such as chemical differentiation via gentamicin or vestibular neurectomy. At that point, the deficit becomes stable. There are no longer fluctuations because the ablation has occurred. We are then rehabilitating a Meniere's patient who no longer expresses high drops, but rather instability resulting from a stable unilateral deficit.
Staying with the focus on patients, in your opinion, and based on the experience you've gained over the years, are patients always able to clearly express what they are feeling, or do they sometimes struggle to find the right words?
The majority of people struggle to find the right words, but that's likely because our vocabulary isn't as specific in defining balance disorders as, for instance, the English lexicon is, where there are two macro distinctions between spinning vertigo and instability. Now, I don't want to suggest that spinning vertigo is always a peripheral disorder and instability is always a neurological or central one. That classification belongs to the past and is no longer suitable for the present, nor will it be in the future. However, people express themselves in the way they find most appropriate based on their own experiences, their background, and their socio-cultural level. We have to be skilled at interpreting that discomfort to correctly place it within a clinical, anamnesis, and instrumental context.
Excellent. And if we wanted to summarize the most common and characteristic symptoms, those that typically lead a patient to be referred for vestibular rehabilitation, what would they be?
The most common symptoms are, generally speaking, disequilibrium and instability, which manifest in various ways. They can present as mild, moderate, or severe, but the core symptom is specifically instability or disequilibrium. Resulting from what? Resulting from vestibular damage. We can go into more detail later, perhaps, on which specific vestibular damage produces a certain symptomatology. However, these injuries can be unilateral, partial or complete, or bilateral, partial or complete. Inside the ear, we have different receptors, the semicircular canals, which handle angular and rotational velocities, and organs that allow us to perceive linear acceleration, namely the otolith organs and the maculae. We, and specifically those of us handling the diagnostic side, must be selective in describing which of these parts is malfunctioning and which specific symptoms it is generating.
Crystal clear. Now, in common language, we know that terms like vertigo, instability, or dizziness are often used interchangeably. How important is it to clarify these differences right at the very beginning of the patient's journey?
Well, it is incredibly important to define these aspects clearly, and I repeat, not by framing them as a definitive diagnosis, because vertigo can originate from the ear or be neurological in nature, just as instability or dizziness could be a peripheral disorder, perhaps during a non-compensated phase. However, clarifying these aspects is vital because educating the patient allows for better feedback regarding future events, the progression of the disease, and the progress of compensation. If the patient truly understands what we are talking about, which requires taking the time to explain it, sometimes a lot of time, it leads to positive returns and better comprehension. Most importantly, the patients themselves understand exactly what they are doing, what they are achieving, and how their symptoms are evolving.
Very well. So we've understood that a fundamental aspect is to first understand the patient before moving on to performing various tests. When a patient arrives with vestibular disorders, what are the aspects that you consider essential to explore and understand immediately?
This is a crucial question because we have always said that vestibology is built on the anamnesis. Diagnoses come from the clinical history. Evaluations start with a careful interrogation. It might sound like a harsh word, but it accurately describes the fact that you really need to talk with the patient. The aspects that are essential to explore immediately are their actual experience and their narrative, what they feel now, what they felt then, and the specific characteristics of the vertigo or instability. When did it start? What happened beforehand? What were the primary or secondary triggers? How long did it last? How did it resolve? Were there associated symptoms before, during, or after the event. Then there is the patient's habitus, meaning what kind of internal medicine evaluations they've had, what medications they take, whether they live alone or with a spouse, and if they are elderly, whether they have children to assist them. These are all aspects that become incredibly useful for future management if the person enters a rehabilitation program.
Right, so after the patient's initial narrative and above all careful listening, we know that instrumental tests come into play during the patient's analysis. How much do they help in daily clinical practice, and how can they be integrated with the clinical history that has been taken?
Earlier, I mentioned the Tuscan School of Vestibologists, and I'll borrow a term I learned there: Franciscan Vestibology, essentially poverty-stricken vestibology. I started exactly like that, and I'll use that to answer your question. Back then, we had a treatment table, a pair of Frenzel goggles, and if we were lucky, a syringe to perform a thermal test, strictly monothermal, as we didn't have an autocalorimeter, let alone an air-based one. What do I mean by this? I mean that clinical observation forms the basis of the diagnosis. You must learn to examine the patient on the table using clinical tests. A well-structured battery of clinical tests already completes more than half of the diagnostic journey. In recent years, and I admit this gladly because I use it extensively, technology has helped us quantify what we previously could only observe qualitatively. Now we have actual values and numbers. We can identify not just which system is malfunctioning, and I use the word system intentionally, but also how the vestibular system reacts to the dynamics of movement, thanks to recent research papers. We are moving beyond simply saying one canal isn't working or all 5 vestibular organs are failing. Now, we are looking at how the labyrinth responds to stimuli. Not all pathologies involve damage to all the nerve fibers responsible for slow or rapid movements. Sometimes both systems are dysfunctional, sometimes only one. Therefore, technology is helping us determine the dynamic response to movement within the vestibular system with much greater precision.
Moving on now to the therapeutic approach, let's say, without necessarily getting too technical, can we still identify the key concepts on which vestibular rehabilitation is based?
Well, vestibular rehabilitation, as we said earlier, is essentially a process of sensory reorganization. So I think we can quite confidently say that we've moved beyond the traditional framework we used in the past. The idea of exercises aimed purely at habituation, exercises focused on adaptation, or exercises designed for substitution. Instead, we need to blend these rehabilitation techniques together in order to neurologically reorganize a kind of symphony that has been lost. If you go to the theater and listen to an opera and certain elements are missing, that symphony loses its meaning. Sometimes a specific instrument may no longer be able to function as it once did, but other instruments can step in and compensate, recreating a functional state that still allows an acceptable performance for the patient. At the same time, the patient needs to be aware that some situations may still cause discomfort even after rehabilitation. But generally speaking, when patients understand the available possibilities and adhere to the therapy, the reduction of symptoms helps them feel reassured. They see positive results and feel satisfied with the progress they've made.
Absolutely. And from this perspective, another very important element emerges: the subjective aspect, which plays a crucial role when we first take a patient's medical history and later when we design the treatment itself. In your experience, how important is it to tailor the rehabilitation path to each individual patient based on their specific needs, rather than strictly following more rigid or standardized protocols?
A rigid protocol certainly solves a lot of problems, that's true, because everyone ends up doing the same thing. But it isn't built around the patient. Every patient has different needs. Each person is unique from a functional point of view, and every vestibular disorder is also different. That's why, as I mentioned earlier, it's important to understand how the labyrinth reacts to movement dynamics If the labyrinth starts to malfunction under a specific type of dynamic condition, then that's exactly what I need to train. In other words, I tailor the rehabilitation to that specific dynamic condition rather than focusing on one where the dysfunction doesn't actually appear. Or I may decide to work on all the mechanisms the vestibular system uses to manage movement: gaze compensation, gaze stability, and overall balance control. But this decision must come from both the patient's medical history and, most importantly, from instrumental diagnostics, which allow us to identify exactly where the system is failing. Once that weak point is identified, I design the exercises in that direction. So rigid protocols? No. Vestibular rehabilitation should be evidence-based, absolutely, but it must also be personalized.
Great. If you agree, let's now go a little deeper and look at some common clinical scenarios. For example, is vestibular rehabilitation also useful in cases of BPPV, or is the repositioning maneuver alone sufficient?
Thank you for the question. It's a very interesting one. In Italy, we're influenced by a school of thought from the United States, where vestibular rehabilitation, if I may put it in parentheses, is considered a form of physical therapy that also incorporated the physical maneuver used for otolith repositioning. As a result, some people think that canalithiasis, meaning positional vertigo, should be treated with a physical treatment called vestibular rehabilitation or vestibular re-education. But the physical therapy used for otolith repositioning is not the same thing. It's a repositioning maneuver, a physical treatment that has nothing to do with the rehabilitation we're talking about here, namely balance rehabilitation. Therefore, in cases of canalithiasis, we usually stop at the otolith repositioning maneuver only in certain selected cases. When frequent recurrent episodes of positional vertigo caused by canalithiasis have led to a chronic dysfunction of the system, do we consider vestibular rehabilitation. At that point, once the labyrinth has been cleared of the scattered otoconial material inside the canal, vestibular rehabilitation can also be introduced, but the two are completely separate things.
More broadly speaking, what role can vestibular rehabilitation play in complex or chronic conditions?
First of all, I should clarify that I don't deal with the rehabilitation of severe neurological diseases, nor do I intend to take the place of physiotherapists who work in functional therapy, such as treating functional disorders of the musculoskeletal system, for example, motor issues or problems related to proprioception. That said, the current literature tells us that the labyrinth acts almost like a gateway. It's an access system that connects with many cortical and neurological areas, especially when it comes to central pathologies. In the scientific literature, we're seeing more and more studies discussing severe strokes or forms of Parkinsonism that respond positively to vestibular physical therapy, and this clearly opens an important door for research without a doubt.
So once the patient's visit and medical history have been completed, treatment for the condition begins. What factors influence how successful the therapy will be?
There are factors that depend on the subject, so on the patient, and others that depend on the clinician. The elements that influence the outcome the most can be found on both sides. On the patient side, what has the greatest impact is their motivation, the desire to achieve a result, their adherence to the treatment protocol, and of course the specific characteristics of the dysfunction we are treating. That's a simplified explanation and unfortunately not exhaustive given the time we have. As for the clinician, their role is first to make a correct diagnostic assessment and therefore to design a rehabilitation program that is tailored to the dysfunction. But before doing that, they need to fully understand the condition. Then they must motivate the patient in the right way to help them reach their goal. Many people stop doing things simply because they're afraid they won't be able to do them. When we manage to help someone who may have been sitting in an armchair from morning to evening start doing things again that they hadn't done for years, that can be incredibly motivating. But it's the rehabilitator or clinician who has to mediate between realistic expectations and the actual progress being achieved. It's important to point it out when something works, when something goes well, when improvement is happening, and to encourage the person to keep going in that direction. Of course, expectations must always remain realistic and aligned with the condition we are treating. We shouldn't ask too much from someone who can only give a certain amount, but at the same time, we shouldn't ask too little from someone who is capable of much more.
Based on what you've just said, it seems that patient collaboration plays a central role once the treatment phase begins. In your experience, what can be done to improve that collaboration?
Patient collaboration plays a very significant role in determining the outcome of rehabilitation. A cooperative patient, someone who follows the treatment protocol, is much more likely to achieve a better outcome compared to a patient who does the opposite. As I mentioned earlier, technology can certainly help us highlight the results. Sitting down with the patient, perhaps halfway through the rehabilitation program, and showing them what has been done and how far they've come can make a big difference. This can be done with the help of diagnostic questionnaires, but especially through instrumental tests that clearly demonstrate the progress that has been made. Seeing that progress can improve the patient's level of collaboration, particularly if it was somewhat lacking at the beginning.
So it's also important to make the patient aware of the progress they're making.
Exactly.
Looking a bit into the future, let's say a few years from now, how do you imagine a possible future evolution of this field? That is, the technology we've been talking about so far, such as possible virtual reality or possible rehabilitation, in your opinion, are these real opportunities? Are they concrete or not?
They are certainly possibilities worth exploring. As far as technology is concerned, at the moment it mainly helps us deliver stimuli more precisely, at least in the type of rehabilitation I practice, which is primarily visual-vestibular. That means visual targets and movements, sometimes with head movement and sometimes without, with specific accelerations. Technology helps because it allows us to deliver very stable and controlled stimuli. So in that sense, technology is definitely useful in rehabilitation. Perhaps it isn't absolutely essential because we can also work in simpler ways, as we mentioned earlier, even in rehabilitation. But when technology is available, it certainly increases patient adherence. It helps patients become more aware of what they are doing and of the progress they are making. So technology will definitely accompany us in the future of rehabilitation. As for virtual reality, I'm not a great expert in that field. And at the moment, I wouldn't say I'm a huge fan of it either. But I wouldn't rule it out. I think we should focus on creating truly realistic scenarios, less gaming and more everyday environments, like a supermarket, for example. Telerehabilitation is another important area. Since the COVID pandemic, we've inevitably started interacting with patients remotely. Having systems or apps that allow us to monitor the exercises patients do at home can be very useful. That said, I still believe we need to see patients in person. We need to observe them directly, face to face, how they move, where they look. The patient must remain at the center of the process, and maintaining that central role from a distance may not always be easy. Still, it's an opportunity we should keep open.
So the idea is to take advantage of technological progress while always keeping the patient at the center of the problem.
Let me add one more thing, if I may. These are all those sophisticated devices that we are currently studying, wearable devices that remotely monitor patients, people undergoing rehabilitation, or even those who have not yet started the rehabilitation protocol to understand if there are sensitive biomarkers, perhaps indicating the risk of falling or gait disturbances. I believe these two represent the future, though unfortunately, they are still too confined within laboratories. They need to be developed through research and clearly through technology transfer so they can be brought out into the real world. Why do they need to be brought out? Because our goal is not only to improve the well-being of people undergoing vestibular rehabilitation, but also to reduce their risk of falling. Because at the end of the day, when an elderly person reduces their risk of falling, it has an impact not only on their physical health, but above all, it has a huge social and economic impact. In fact, we know the dire and harmful effects that falls have on elderly people. Our objective is to reduce this risk, clearly, even though we cannot eliminate it entirely because that's impossible. This is regarding elderly people. But vestibular rehabilitation, to open a more futuristic parenthesis, is also about enhancing performance, increasing performance in athletes or in those who need special balance skills, such as performers on stage, for example. This is now a major field that we are trying to better understand and in which we, as the University of Turin, are actively involved. There's also the microgravity context, meaning space flights. What happens during, what happens after, and how can we help astronauts to improve and better manage dysfunctions related to changes in gravity, which clearly have a significant impact on the balance system. This is to give a general overview, not just about the present, but more about the future.
Certainly, it is absolutely a cross-disciplinary field. So, to conclude, I'd like to ask if you have any advice you would give to a young clinician who wishes to approach, let's say, vestibular rehabilitation.
People often say that in vestibology, you either love it or you hate it. Some people end up in this field by chance, perhaps because a position needed to be filled, as happened to me, while others choose it deliberately. In any case, if someone decides to pursue this path, my advice is to keep studying, open the books, read the scientific literature. The literature in this field is extremely active, perhaps even more so in recent years. It's also very important to seek interdisciplinary collaborations, talk to professionals from different fields who deal with balance in different ways. This broadens your perspective, encourages discussion, and allows for brainstorming. That kind of exchange is incredibly valuable. It helps you stay motivated and curious, and it helps you understand aspects that may still be unclear. And then, of course, work with as many patients as possible. When you have the opportunity, work with them directly, face to face, examine them, perform diagnostic tests, use clinical tools, and talk with them, because this helps you understand a system that quite literally helps us stay in balance.
Well, Doctor, I thank you very much for being here with us, for sharing your experience and your work. And we can say that if those who listen to us today are able to look at vestibular rehabilitation from a slightly different perspective, then we have achieved our goal.
Thank you.